Because as you can see, I move around. I'm sort of one of these people who get a bit agitated and stuff if I'm sitting still. So I wanted to do a really interactive workshop. We'll still try and do that, but it's a bit hard when we've got this many people to do group work. So at 2 o'clock in the morning, I revised my plans, seeing how many people were probably going to turn up, and I'll cross my fingers and see how it goes. So first of all, here's our topic, oral nutrition supplements in older people with fractures. So that's the topic I was landed with. And first of all, I would like to introduce our surgeon and president incoming in 2 days, Frede Frihagen. Where are you, Frede? That's yours, and I'll shake your hand.
Thank you.
Thanks.
Thanks for inviting me, Jack. In 2 minutes, I'll tell you about the fridge. Last year, when I went to Melbourne, I had the extreme pleasure of meeting Jack. It was easy to meet him. I mean, you can see him, find him, hear him. And we had some really nice discussions about, among other things, interdisciplinary treatment and nutrition. And I made a slide. Low-hanging fruit. I may have said that. Nutrition is a low-hanging fruit. And as you understand, he has now asked me to explain what I meant. It may be my poor ability to use metaphors and proper idiomatic English, because low-hanging fruit is like easy to pick, yeah? So is nutrition easy? That would be stupid to say, and especially stupid by me, who is not knowledgeable enough about it. Of course, it's complex. Injured, sick, old people who need fracture treatment. And some of us may sort of be overwhelmed by that. We think it's too difficult, and I don't think it is. But we don't have access to a dietitian, at least not every day at the ward. Most of all, it goes for most of us, I think. But I think perhaps what I meant was that to us in our hospital at the time, nutrition was low-hanging fruit because we were so bad at it. We had been doing this improvement work for all people with fractures, and we had gotten improved surgery times, we had got improved fluid treatment, we had got improved osteoporosis treatment, and we sort of delayed doing it. We had nutrition in our guidelines, but we delayed or didn't pay enough attention to it, and at least not in the beginning. So that may defend my statement of low-hanging fruit. This is low-hanging now then. These are my youngest children after we have harvested apples. Anthony Johansson published several years ago a randomized trial where he gave half the hip fracture patients a friendly person assisting them at meal times. And the other half got same tray with the same food on it, but no friendly person. And at discharge and at 1 year follow-up, mortality was much lower in the mealtime assisted group, which is, it's a fascinating trial because that's really, that is easy. At least we should believe that, but the project was stopped straight after the trial because they couldn't fund those friendly assistants, so it's problems there too. We had in our guidelines at the hospital that hip fracture patients should get nutritional supplements. And we realized that they didn't get enough and not for long enough. So I'll tell you about a few barriers. We didn't have enough knowledge about nutrition, none of us really. And we set up some really simple education days where nutrition was a part of it. And mainly we let the nurses, we gave a few selected nurses the task to work with the nutrition to give the education. And the nurses would give the education to the other nursing and nursing staff and to the surgeons and everybody else. That worked really well. And then we got a few nurses with ownership to the nutrition topic at the ward. We also realized that we screened all the patients because that's obligatory in our hospital to do nutrition screening at admission. But we never ever looked at it again. So we didn't do anything about it. That was a real waste of resources. That's expensive. And embarrassingly, doctors, we learned about reimbursement rules so that we could actually write prescriptions for oral supplements after discharge so people could get it for more than 4 days. And then we bought a fridge. I promised to tell you about the fridge because the fridge with the nutritional supplements, that was outside the ward and was far too long to walk in everyday practice for the very busy nursing staff we have at our hospital. And now we have the fridge I showed you at literally arm's length from the hip fracture patient, and that has improved it too. So thank you for listening, and I am a very sort of fresh, enthusiastic student on nutrition, and we're seeing some great results at our hospital now, and I'm very optimistic for the future. And thank you for letting me sort of explain myself of the perhaps typically orthopedic rash statement I made that it's low-hanging, because it's not all that low-hanging, but we can improve. Thank you.
It's over to me, I think. Thanks, Freddie. So, I always think it's nice when you can start a workshop with the incoming president, so thank you. And especially, again, if I bring it back to 25 years ago, the fact that we have surgical champions who are doing this. I know Hannah Seymour is probably floating around here somewhere as well. Are you here somewhere, Hannah? Anyway, so Hannah is a dead set nutrition champion as well, and she was the president. We've got Lauren. So it's great. We're here. We're talking about these things. So the next person I'm going to introduce, who I've worked with for quite a while now, and I still am very terrible at Icelandic, but I'll give it a crack. It's Olof Guðnýgeirsdóttir, and I've done it wrong again. And she's going to talk to us about where things fit in the bigger picture. So over to you, Olof.
It's so nice to see so many people, and I'm sorry to say I'm so surprised as a nutritionist, and I have done several talks abroad about nutrition. I have never seen so many people in a room, and I know here is not so many nutritionists or dietitians in this room, so it's really nice to see you all. The task of my talk is to put everyone on the same page about guidelines so we can work together in this workshop. I have no conflict of interest to report, and I will talk about the Aspen guidelines, which you see here. Though there is no single best nutrition intervention, oral supplements are the best we have today. And I will discuss Aspen recommendation about oral supplements. When we look at the general principle of nutrition care according to the Aspen guidelines, we have guidelines for nutrition intake, that is enough energy and protein intake, and correct or any of micronutrient deficiency, and we have to keep good hydration. And for a basic principles of nutrition care, when we have to have enough energy and protein intake. We have to consider fibers and be secured about the hydration for our patients. So for all patients, not only hip fracture patients, for all patients, elderly patients, the standard procedures for nutrition and hydration care shall be established and well regulated. According to the recommendations, nutrition and hydration care for older persons should be individualized and comprehensive to ensure adequate nutrient intake. Nutrition intervention should be part of multimodal and multidisciplinary team intervention. And potential causes of malnutrition and dehydration shall be identified and eliminated. Dietary restrictions should be avoided. Healthcare professionals as well as informed caregivers should be offered nutrition education. And now you are supposed to think, do we all do that? Or are we doing this? And when we talk about prevention and treatment of malnutrition, we should involve supportive interventions like nice atmosphere and easy access to nutrition-dense food, and nutrition counseling, food modification if needed. Then we have oral nutrition supplements when dietary counseling and food fortification are not enough. And when our patients are old with or at the risk of malnutrition, to increase dietary intake, not instead of food, and we have to think about oral nutrition after discharge from the hospital to lower the risk of the functional decline. When we implement oral nutrition, we increase energy and protein for at least a month. We can't just use it for 1 week or 2 weeks, at least a month, according to the recommendations. And compliance on the oral nutrition recommendation should be assessed and adapt for the patient's needs and eating capacity. And in the case of specific disease like hip fracture, we should offer oral nutrition supplement post-operatively, and where nutrition intervention for geriatric patients after hip fracture and orthopedic surgery shall be part of individually tailored, multidimensional and multidisciplinary team intervention. These are the recommendations, and the question is, are we working according to the guidelines? Thank you.
So that's a good question we find ourselves asking. I see a few people have got mobiles in the room, so that's good. So keep them warm, because we'll be using them in a minute with some interactive work if the technology works, and I'm a little bit nervous about that. But anyway, we'll keep going. So are we working according to the guidelines? Well, we've got a local who's here to talk about their experience first, and then I'll introduce both at the same time so they can just follow one another. So Cicel is going to talk to us about what happens in this neck of the woods, and then afterwards we've got Jose Luis, who's come all the way from Chile, who arrived yesterday. At what time? Yesterday. He doesn't even know what time. And that was, so he's a geriatrician as well. So we've got a dietitian and a geriatrician. So over to you first. There's your clicker.
Well, thank you, and I'm also so delighted to be here today. And I've been a dietitian since 1996 and did my education in the United States and came to Norway, and there was like one dietitian in the whole entire county. So things are are improving. Are we meeting the recommendations, not in Norway, but because I'm going to do it on our ward in Diakonhjemmet Hospital, and I know there are several of us here. And they are the ones that are doing the good job. I have no potential conflict of interest, as I know. this is my hospital. It's a very nice place. And this is the orthopedic ward. And I'm going to walk you through how it is, how they focus on nutrition. We'll take a little step back because the Director of Health developed a few years ago what they call a ladder of nutrition. This is to prevent malnutrition well, before they come to the hospital and during. So if you see on the bottom line here is to ensure that the underlying conditions are taken care of. Because if patients are in pain or discomfort, they are not going to eat. Also, the environment is important. You know, if the patient next to you is on the bedpan, or if it's a smelly room, they're not going to be very appetizing. Or if it's if they are in a room where the lights are off and so on. And then they need the food choices. Do they have the choice that they like? And we have, you know, we have so many different likes when it comes to food, and our hospital has a very high age, so we try to use traditional foods, and I'm going to show you a picture of that. But if that doesn't work, we start with fortification of the foods. And actually, in our ward, we have fortified menu as a standard menu. But then if that doesn't work, we'll do the medical nutrition therapy, as I call it, and that's oral nutrition supplement, tube feeding, and IV nutrition. So this is the nutrition protocol in my orthopedic ward, or I'm not on, I don't work on it, I serve it. They always do height and weight, and they are the best ward in the hospital when it comes to screening. They measure patients' height and weight and a BMI, and once a week if they are long stay. They do give, this is a direct copy, they do give a thiamine if the patient is considered malnourished, is to prevent refeeding syndrome. They monitor the food intake, they monitor the secured fluid intake, and they have a fortified menu as a standard menu. And when it comes to mobilization, they do make sure that the patient is sitting in the chair while they're eating. And sitting in the chair is going to prevent pneumonia and so on. And just being well, feeling more at ease when you sit, you're feeling that you're not as sick as maybe if you're laying in bed. And good oral hygiene, which is an under-focused area, I would say, because dirty teeth is not very appetizing. You just don't feel like eating. This is what we call risk evaluation. This ward has a risk board. When it comes to low-hanging fruit, if you see, this is a whiteboard, it's taped or marked, and it's not very fancy, but it works. So all patients are assessed for risk of falling, medications consensus, BMI, and they have a plan of discharge, and they are making sure that all patients are assigned to a physiotherapist. The R, which is risk of falling, they will say, is this patient risk of falling? And if it is, you know, it's supposed to be actually a slippery man, but I think they ran out of magnets. But if this patient is at risk of falling, they will have next one, you see here, are the measures taken? And that could be fall mats, so they can be sure to secure the beds and so on. And they make sure that they have a physiotherapist and make sure that the BMI is calculating. And also all the patients has a discharge plan. So every day at 11 a.m., the head nurse will go through this board and assess if patient has fulfilled their requirements. And if the patient is malnourished, they will do put nutrition on their electronic chart. And will start monitoring their food intakes and fluids intake. And if they're not eating, they might offer them a la carte, or they might have food that's high in calories and protein, or small meals in between. So the fortified menu, this is what they served 2 or 3 days ago. It's lamb, cabbage, and potato, a very traditional food, which the older people is going to recognize. But the fortified menu is half the size and supposed to be the same calories. I'm not sure if it is, but it's supposed to be. And that's important because most of the patients do not have the appetite of eating that large portion on there. We're quite generous with oral nutrition supplements, but mostly it is for patients not eating adequately. And according to ESPEN guidelines, everybody should have it, I know. But patients with low BMI will get them. And it's a written order usually, and they will write type and order, and the nurse needs to tick off if, I'm not sure if it's consumed, but at least when it's provided. The survey that we have done, made by Jack Ba here, it says that 56% of the answers in Norway think that we are serving oral nutrition supplements to patients after surgery. I'm not sure. I'm not done. I haven't checked it, but it might be that over half of the patients are getting oral nutrition supplements. So when do they refer to the clinical dietitian? They actually do refer when the patient is getting into the room, into the hospital before surgery. And if it's involuntary weight loss, and if they're less than 70 years old and have a BMI under 20.5, they will also refer to us if they have a BMI, if they're over 70, have a BMI under 22, and weight loss. I think we skipped the weight loss. It's an automatic. If they have less than 22, they just automatically refer to us, and we will assess if they need it or not. And if they eat less than 50% of their meals, usually they tried a lot of measures, but it doesn't work for the next 2 or 3 days, and they will refer to us. Because we are quite heavily staffed, so patients are referred to us before noon, we shall look at them. For us, it's something that we have to do. If not, we get a mark in our, if we get marked. So it's a service that's probably not as usual as I'm hearing in other hospitals. But after they have been discharged, there will be follow-up after 3 months with a physiotherapist with an X-ray. And at 4 months, people that are over 65 years old, usually the ones that are morbid or frail, so they will be seen by a nurse, and the nurse will ask about the nutrition. They will also weigh the patient, and they will also provide them with a bone health pamphlet that includes nutrition. And then, I think maybe we are the only one in Norway, they will be asked to participate in hip fracture seminar. We have something called a Learning and Mastery Center in Norway. It's called the Education Center, and offer mainly group-based seminars. And we had user representatives, which is that kind of professional patients, and we have different professions. So we have 2 days or 8 hours of education seminar called After Hip Fracture, and you can see that we are quite many professions that are talking to these patients. So I think we are not perfect, but I think it is it's quite optimal, to be honest. Okay, thank you.
Well, good day. First of all, I want to thank you, Jack, for inviting me to participate with him and his team and with you today. So, I am José Luis Dinamarca. I'm from Viña del Mar, in the 5th region of Chile, in the center of our long and narrow piece of land. I have one little potential conflict of interest to declare, and that is I am speaker of Procter & Gamble in vitamin B12 issues. Well, how is Chile going with the key recommendations? And unfortunately, we are not so good. As you see here, in the blue bars, both blue bars, especially when we compared us with Norwegian. In these 4 graphics, we have percentage of special menus, percentage of offered oral nutritional supplements, in the second one, in this one, percentage of oral nutritional supplements provided at least 1 month and assessed, and percentage of provided nutritional information. And in all these graphics, we have that the 50% half the time, and the other 50% hardly ever or never. So after seeing these graphics, I asked myself, WTF? As you know, this means, who is the father? And I must share with you some thoughts about this. First, we need to consider the patient balancing food for life with nutrition as medicine. So this is an ancient Chinese phrase that says, please eat thinking that your food is your pills, for not to start to eat your pills as your food. You know it. Because good nutrition starts with a food, and food is a problematic issue because everybody, including us, thinks that he or she knows how to eat. Yes? Every people, especially older adults, have his customs, traditions about food, about meals, and after a long life, well, people are not able to change it easily. A very important barrier is how we, health agents, how we put, and this is a funny phrase, how we put the food problem on the table to eat it, including the biography of our patient. The second thought is we must empower our patients and staff through education and engagement. People thought first that therapeutic food has bad taste. And in second place, people think that free things are bad, and that is one of our problems in Chile. We have very good supplements, but people think that it tastes bad. And one of the problems is that nobody tells people that these supplements are very important. They must complement or supplement their daily diet with this super supplement, but we must explain to them. And the other thing is we could be not really enthusiastic to explain our people these issues. So we could be very boring for them. Especially they are being in bed, they are being hospitalized, and we start to speak of blah, 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 this is very important. No, we must be enthusiastic. And we must work together as a team. Well, that's a very big truth. Our organization is a multidisciplinary organization, and within our mind, if we really work as a team, we will know the importance of the diet therapy. So we will include the time for education about nutrition in our agendas. So we must improve our way of function as a team. And why are these things important? Because these reflections. During our evolutionary period of more than 5 million years as a species, we, human beings, have gradually changed our source and methods of food supply, our content of our diet, our customs associated with intake, and along etc. of variables. And this has produced profound genetic, anatomical, physiological, cognitive, and social changes, which in turn have influences these variables back. So the same happens with older people. Their nutritional behaviors has been acquired through his whole life path. So I think that if we really want to impact the nutritional behaviors of our population of older people, we must start influencing the older people of tomorrow, our children. As Dooley Wilson sang in As Time Goes By, you know, in Casablanca, and Brooke Bulling in another television shows, it's just a matter of time. Thank you.
Okay, so we may have tricked you a little bit because, you know, this session was called Oral Nutrition Supplements. But I'm sure by now you probably realised that it's not just about oral nutrition supplements because, as you saw from what Olaf presented earlier, it needs to be part of interdisciplinary multi-component care. So I've added a little bit extra to our initial thing because otherwise it's just not going to happen. And even when we're talking about oral nutrition supplements, we've got a professor up the back who'll be very quick to point out that we need to adopt a very broad view of what oral nutrition supplements are, because ice cream, especially if it's fortified, can actually do a really good job. For some people, I don't actually like ice cream. I'd prefer to have an extra piece of steak, but that's me. So, I think I've already declared that, but I do lots of things in FFN, and FFN does include industry partner funding. Thank you. So, have you guys got, if people have mostly got a phone, there is free Wi-Fi. You don't need it just yet, but you can just in the meantime look up. I promise I'll give you at least 30 minutes of interactive workshop because it is called a workshop, but we did need to give a bit of context. So I've got about 10 minutes worth of context, and then the rest of it, if the technology works, again, gulp, we should be able to have some fun. So, sorry, I'll go back. No, I won't. So about, I don't know, 3 or 4 weeks ago, I was dumb enough to go, let's try and do a global survey that we could do really quickly and pull that data together and then maybe do 14 or 15 interviews and then pull that data together and then maybe use that to inform a few presentations earlier in the week to then lead up to a plenary, which I'll be doing tomorrow. I don't know what I was thinking, but it looks like we're getting some stuff. So 47 countries have responded to that. And I will provide one of those QR code things at the end. So if you haven't done it yet, you can feel free to fill it out. It takes about 6 minutes and 8 seconds or something, I think, is the median. It's 274, so that's kind of facility level data, so because it's talking about people's institutions. So as you can see, we've got a U-shaped curve pretty much for people getting good food. So when I say good food, I mean if you're talking about people with fragility fractures in hospital, generally they don't eat enough, as we heard in the lunchtime session. And so we really want nutrient-dense, high-quality choices that people are going to make the most of eating. So next up, we have, how often do you think oral nutrition supplements are offered, and I use that word because that's the word that the ESPN guidelines say. When you've got guidelines, you have to be very particular about your wording. And when you're doing a global survey without ethics approval from everybody to do individual data, you clearly can't go around measuring individual patients and reporting it at a conference. So it was just people's perceptions about what's being offered, not how much people are actually consumed. But I'll be the first to say that if you don't do the right things, they stack up at the bedside, and I've got 25 years of experience of watching that happen periodically, depending on how often we as a profession drop the ball. So it's less U-shaped, but if you look for the blue and the orange, it's unlikely to make up half. So really, there's less than half of people or facilities who are offering oral nutrition supplements often or all of the time. Now that is the key. It's recommendation number 43 in the ESPN guidelines, specifically for hip fracture. So we're not doing it. At 1 month and assessed, because I don't think that we should be offering them for longer periods of time without follow-up. It's not economically responsible, and it's just, we don't know how much these people's individual requirements are. And so if you're giving medical nutrition therapy, you really need to make sure you're following it. We're doing a terrible job of that globally. And again, that is the ESPN guideline, almost word for word. Sorry. Yeah, I'm up to the next one. And then finally for this one, which is, how often do you think nutrition information, education or counselling is provided? Now, okay, I'll give an example. We probably don't have any renal physicians here, but has anybody heard of Rosonium? It's something you give to people if they've got really high potassiums. And it's like drinking my daughter's rosin that she uses on her cello bow. It's disgusting. But people drink it because when their doctor says, if you don't drink this, you're probably going to have a heart attack tomorrow. So they drink it. And they drink a whole stinking big glass full of it. And it's like just walking up to a tree and sucking the life out of it. And yet we are giving over double that amount of people supplements in facilities and not telling them why they need it. We're not telling them they've got malnutrition. So why would I drink a warm, sweet drink? Or why would I eat the protein when I don't usually eat very much protein at home anyway, if I don't know that I've got malnutrition, which is actually a stronger predictor of my outcomes than how good my surgeon is, or what sort of technique he used, or how long he took the patients to get to surgery, or the team. Let's not blame the surgeons for that. It's very rarely the surgeon's fault to get people late to surgery. So, now we collected this on all of them, but I'll just show the last one. And that's to show that we don't need to rely on dietitians to do this care. And in fact, globally, if we do, it comes way too late. We want dietitians to be doing the stuff that dietitians have been trained to do and are paid to do, which is expensive stuff for people who actually need specialised care. And it's great to see that nursing staff, doctors, assistant staff, and other allied health, if you add up all those bars to the right of the blue one, that adds up to a whole lot more than dietitians. So we actually have, pretty much in many sites, hospitals worldwide that I've been to and visited, a really large untapped resource when it comes to nutrition care. So I scratched my head and looked at that data when it started coming in and said, I've got to do some interviews before we come here because I really need to get to the bottom of this. So I was lucky enough to interview 14 different people so far who are change agents, interdisciplinary leaders across FFN. So these are some of the smarts, the brains trusts within FFN, and we've got, 500 or 600 brains trusts here. So I'd love to interview all of you, but I would die. So anyway, we've got 14, and it's nicely spread, low, middle, and high income countries. And our initial question, noting that I'm a very, very loose interviewer when it comes to semi-structured interviews, so it was quite semi on the structured side of things, or unstructured. So we started there and the conversation went in all sorts of places, but really looking at what determines whether all older people are offered oral nutrition supplements after hip fracture surgery. I then have done a very quick mapping of that to determinants of what some of those barriers and enablers might be, and then behaviour change techniques. And out of that, we've pulled out 8 different key things that could be done that I need you to focus on as part of this workshop moving forward. So the first one, identify interdisciplinary multi-component care as a high priority in FFN frameworks, pathways, policies, position statements, and processes. I'm just going to be quiet and let you guys read some of those quotes for a sec, because some of them are pretty good. Now, I'll start making it a little bit interactive, although this is the interactive part of it. Is anybody bold enough to disagree with any of those things? Okay, I'll go the other way, I won't go. Does that resonate? Put your hand up, show me if that seems to resonate. We go on, put them right up, you've got to own this. The problem is we don't have any accountability. Okay, so maybe half of the people think that's all right. Well, we'll keep going in. We'll find out a bit more later. So we need to publish evidence-informed implementation guidelines, or something we've argued over what we'd actually call this, because we don't want to reproduce the evidence-based recommendations. So it's more like an implementation approach, or some way of saying, pretty simply, what is it that could be done that could be tailored locally to then actually make these things happen. I won't go through all of those. The slides are available and you can press pause. When do these things come up online? Is it like 3 months or?
We're streaming now, actually. So
okay.
you can see it on the phones if you like.
Great. Okay. So don't use your phones too much though, because I need them to. And there's some possible ideas to work up that I'm not going to talk to now, because these might not be them. We actually need to do genuine co-design with patients and all sorts of things to actually look at what they might look like. But again, these are linked. Most of these are actually quite well evidence-based, not even evidence-informed. Development of a pathway is really important, and so these need to be built in. We need to create a pathway for the 80 to 85% the match pathway. A pathway doesn't have to be for everyone, so you don't have to worry about what if they've got renal impairment. I don't find too many geriatricians who actually worry about protein intake with people with renal impairment anyway. They usually just say they're not going to eat enough, it's fine. But you can have a pathway so that it says, if you're worried about that, you can just put that in somewhere. A toolkit seems to be another thing that FFN could definitely help with. So again, I'm not giving you the answers yet. This is about what are the priorities that FFN over the next 2 to 3 years can look at to say, here's the things, if we are going to actually change those graphs I was showing earlier, what are the priorities so that then we know which ones we really need to focus in on and then work to changing them. And hopefully when we repeat this in a couple of years' time, we can show that we've made a difference. There's some of the things that could be in the toolkit, but as Jose Luis showed us earlier, I think sometimes having quotes is a very powerful thing. Patient stories is even more powerful. So these are the kind of things that we need to do, not just randomised controlled trials or forest plots or any of those other things. And then establishing audit measures. Again, audits are just as important at the other end of things. So you have stories at one end and then audits at the other, because you do need data. And then we're probably thinking, I don't want to create a nutrition special interest group. I'll be straight out there, I don't think that's appropriate, because nutrition, like everything, is everybody's business and it's spread right across, the whole pillars of FFN. It's a cross-cutting issue. But we probably do need to form some sort of a group to tackle this moving forward over the next 2 to 3 years if we're going to develop FFN resources to do that. And then curriculum, so important. And so we've got EduCom here, so we've got members of the education team, so we're working really hard to do that. I think we need to continue to do that. Here's one, there's nothing in there specific about nutrition, and I can vouch for that. And maybe lead research demonstrating the cost effectiveness of interdisciplinary multi-component nutrition care. There have been a number of people talk about the fact that it can be quite difficult to actually take it to your health exec and push for something if the data's a bit rubbery. But I will say that nutrition studies are very difficult to isolate to a specific thing. So sometimes data that seems to make sense is probably all that's needed. So here's where the fun starts, I'm hoping. So before you click on it, I'll give you the caveat. I'm really hoping we can actually publish something out of this done as a quality assurance activity. But to do that, we've got no ethics, but I'm doing it as a QA within one organisation. So you don't have to participate. Your participation is voluntary, but if you choose to participate, you can click on that. You can read the fine print that says it's totally anonymous and I can't identify anybody in here in any way, and you can't see who else is doing it. And if that's the case, feel free to click on that. And then what we're going to do is we're going to go through, and I want, for those 8 statements I had, all I'm doing, because this technology seems to work, is to actually then get you guys to rate whether you think they're important or not. That's all we're doing in this piece of work in the workshop moving forward. So can I just get an idea how many people have got phones and are happy to use it? If you can put your hands right up so that I can... Okay, so that's enough that we're going to participate. Great. If you don't have a phone, just think about it. Just write some points down. If you don't have a phone because you don't have phone access or anything else like that, and if you want to vote, just make a note of your votes. Don't write your name on it. Put it on a piece of paper. There's paper lying all around the place. I've only just sorted this, sorry. And leave it on top of that thing there so you can still vote, and we can get your votes later if you'd like to do that. So see this big speaker box or whatever it is, just like put your votes anonymously on that. So I'll be quiet for a minute or so you guys can go through that and decide whether you're happy with the fine print, and then we'll go from there. I'll get a drink. So the bit I want you... Oh, yeah, sorry. Once you've got up to the yes, I consent and next, if you can put your hand up so that I can see once we've got most people up to that stage. Yep, I can definitely do that. So it seems to be working for some people though, is that right? Great. Wonders never cease. Are we getting close? I think there's... I'd prefer to just make sure everybody's in, because once we're in, we can just take our time from there. And I do believe we've still got plenty of time. Do feel free. I can, if you need to get closer, knock yourself out. Can you get it? Now, if anybody at any stage drops out or loses it, just wave your hand and tell me to go back to the QR code, because I can flick backwards and forwards for this. Are we right to get going, do you think? Does anyone need any more time? Nope? Okay. So, we're at this stage. So some demographics, which please do not enter any personal type information whatsoever. You don't even need to enter this if you don't want to. Just put XXX in the country. If you don't enter anything, you can't go to the next screen. But if you're happy to put down what country you're from, that's fine. And then if you could put down where you work and your profession, that'd be great as well. Does that work all right? Everyone? Yep. Okay. How are people going? They still here? Once people are up to this question, let me know. Most people up to this question? What's that? You're done. Everyone's done the survey. Are you serious? People have just gone through it. You're all too fast. I wanted to talk about it. Okay, so we know who the high achievers are in the room. So I've still got 40 minutes to kill here, so you can't do that. So, and if you click submit, okay, you don't need to put your hand up, but just sort of look guilty when I ask this question. Who has clicked submit so far? Okay, we've got quite a few people have submitted. Excellent. Right, okay, so it's a fine line, give people this much time and they just overachieve and go straight to the end. That's all right, because we can then do the other bit, which is to see if there's anything else, and we can just do that as an engaging process. But I do want to go these for who's left. So, and it's actually, the only problem with the technology is I don't think, unless I can get my mobile through, I won't be able to get it up here. So are people happy to give a show of hands once they've all submitted, so we can't change people's minds? Because the issue with the show of hands is there's their peer pressure. Is anybody still going at this stage? Or is everybody... Okay, we got people still going? Okay, well, how about I just be quiet? I'll give you guys 2 minutes and then we'll talk about it. In the meantime, if the person beside you's finished, what I'd like you to think about is, because I didn't put these on my slides, but I want you to start thinking about what is one thing you might be able to do in the next week when you go back to wherever you came from that you could start as a change process, maybe an individual level thing. What's one thing that you can do? And I also want you to think about over the next 12 months to 24 months, what is one systems level thing that you and your team could start to think about tackling? That's a little bit preemptive because we actually haven't got a toolkit or anything yet, but it doesn't mean you can't start thinking about local change and contributing. So I don't lose the group, I might start talking to these one at a time. If you're still going, fine, just keep going. So looking about priorities, just broadly speaking, can I get everyone to stand up? It's post-lunch and you're all turning yourselves into protein. You don't have to get up, but if you'd like to stand up, that would be great. Make as much noise with your chairs as you can so that then we get used to the noise of these chairs, because I can tell you it's going to be problematic a little bit with the noise of these chairs, and just get used to it because it can be part of the fun. Okay, now you can feel free to sit down on the count of 3. Not yet. If you think that nutrition care should not be a priority. So if you think it's a priority, stay standing. Okay, and if you're sitting down because you didn't stand, that's fine. It gives me enough of a ballpark, okay? Right, so this is fascinating. So clearly then, we all pretty much think it's a priority, right? Have we got anybody who thinks it's not a priority who's happy to tell us why? You don't have to. If everyone can sit down now, and then if anybody who wants to talk to me and the group about that, you'd have to be pretty game, I think. I'm sorry, I should have asked about that first. But okay, so here's a knowledge to translation gap, and it's not even an evidence-based practice gap. It's a knowledge in our heads to practice gap, because everybody pretty much in this room is telling me that they think nutrition is important, right? Is that true? Are we valuing it as an important thing? I'll let you guys decide that. But in the meantime, our graphs are pretty obvious, like they're telling us we're not. Okay, so that's that one. So we had some really robust discussion this morning about this and more generally, because we don't want to do research for the sake of research, and we don't want to put out more recommendations, especially evidence-based recommendations, when it's pretty clear that it seems to make sense what needs to be done and it's just not being done. But maybe it's about the knowledge to practice gap. So the recommendations are there, but they're not just being followed through. So it's probably more about if we can publish like an FFN implementation guideline with an associated toolkit, which is the next question, to actually go, well, here's what ESPN says, or here's what Aspen says, or here's what, pick any other randomised controlled trial you like says, that good care could look like. Or here's just what you should do for your mother who's had a hip fracture, which most of us know, and are horrified then when our mother does have a hip fracture and they're not getting the care that we really think they should be getting, which has happened to many of us, I think. So I guess I'm really interested to know, I don't want anyone to stand up or sit down or anything else like that, but I want a naysayer, not a naysayer, but I want somebody who's game enough to have we got a mic? Yep. Can I get one of our team? I'll get one of our 2 awesome nurses. Karen, are you, Freddie, are you happy to do it? That'd be great. And have we got 2 mics or just 1?
2.
2. So I might get Karen. So we've also got Karen Hertz and Julie Santi Tomlinson who are helping us out on the nursing side just to make sure we've got a rounded out workshop here. So they'll actually go around as well. But who thinks that maybe we don't actually need them and we just need a toolkit, for example? Should we bother trying to have a shiny, an FFN, insert some statement that says, here's like 6 or 8 things that we probably really should be doing as part of care, but it's not just saying this is what's recommended, it's saying then this is how you're going to get there, or these are the opportunities to do that. Does anyone think that that's going to be a waste of our time? Because I'm busy, we're all busy, and I don't want to waste anybody's time. Nobody? Nobody's game to put their hand up. Who's got a yes then? Who wants to give me a really good idea about why you think it might be helpful? Maybe if we could have somebody from a low or middle income country if possible, and then somebody from a high income country. I do want to, I'm going to sit here and be really quiet and do nothing for about 30 or 40 seconds because I do want this to become a bit more interactive. So I'll just wander around on stage and do something. And if somebody's happy to put their hand up and tell me why they think this might be helpful, I'd be glad to hear from you. Okay, we've got a hand over here. Great, thank you. A conversation starter. I'll give you a free coffee later. Was that a short black? A beer, okay, yeah, okay. Yeah, you know we're in Norway, right? Do you know how much beer costs?
Exactly. Is it working?
Yeah.
Yes. Hello, I'm Kirsty Ward. I'm from Scotland and I manage the Scottish Hip Fracture Audit. So you've talked about that there's already ESPN guidelines, and I know that in lots of countries there's standards which are measured against. So I'm not sure of the value of creating another set. Alternatively, if you were to create another set, it would be good if it was editable for each system. And I think the idea about providing a toolkit is absolutely essential, because lots of the work that I've heard here today has been fantastic and I've learned a huge amount, but none of it has included how you actually do it.
Yeah.
And that's the thing that's missing.
So
yes.
maybe rather, so it's almost like those statements can be tailorable local. So I do confess I'm an implementation scientist, so I'm very interested in all of that fancy stuff that sits behind things. But I do think it needs to be locally tailorable. So even in terms of the toolkit, they need to be Word docs, not PDFs. They need to be things that people can take to their even in the same country, even in 2 wards side by side, if you've got different cultures in terms of the leadership within the wards, and particularly nursing leadership, then you need to be able to tailor your toolkit according to that. So thanks.
And it gives it more ownership as well.
Yeah, absolutely. Yeah. And we'll come to data in a minute, but data's the other thing. If you've got local data, that also drives ownership. Great, okay. Is this kind of helpful? If people, you can give me some feedback later. Develop, I'm really sorry, I've only had like 10 hours sleep in the last 4 days and I'm just about to lose the plot. So develop an orthogeriatric nutrition care pathway or pathways. So this is a pathway or pathways. So it's kind of that halfway point. And so hopefully we'll see over the next little while an example of a pathway. It hasn't gone anywhere yet. Freddie, has it? Am I going too early in terms of the orthogeriatric framework? Is that being released at some stage? Or?
Yes.
Yep. Okay, so...
You're just on time.
Right, so watch this space for something called an orthogeriatric framework and think how nutrition might be able to fit underneath that. And again, it's what we've just heard. It's about how you can say, here's roughly, at about this stage in the journey, you might want to think about this. Or you might want to think about that, or you might want to think about that or that. And depending on your model of care, depending on your country, depending on how much coin you've got, whatever it is, that will determine what that specifically is. But we can't just kind of dive straight into a toolkit and let people fumble around and try and find a piece of nugget of gold in there. It's got to be guided towards that. So that's where I think we've got some really strong feedback from the interviews that having a pathway or pathways that again are locally tailorable or modifiable might be helpful. Have we got any againsts for that one? Julie Santi Tomlinson, tell me. Go for it.
So my worry about that is that we have to ask ourselves the questions, does having a pathway impact on what people do? So that's my question about that. I'm not sure, because I'm not completely convinced that makes people do the things that they're supposed to do. I have to be convinced about that.
Okay, so who wants to tell me a story about, and it doesn't have to be to do with nutrition, where a pathway has failed and what that might have been a reason for and whether you're able to fix that? Has anyone got a story about this? Surely in this whole room we've got to have someone who's happy to share that one. Great, we've got a hand, thank you.
Hi, so my name's Evelyn Hannon. I'm an orthogeriatrician from Ireland. So I'm only in the post about 6 months, but our ward identified that a lot of the hip fracture patients weren't necessarily getting started on oral nutritional supplements because on our ward they needed to be reviewed by a dietitian first before they could be prescribed. So they brought in a pathway whereby the doctors could actually prescribe the supplements, but they had to be assessed first. So the pathway was there, but then all the trainees changed, the CNMs changed, the orthogeriatrician changed, and suddenly nobody's getting prescribed supplements on the pathway. So I found out about the pathway about a month ago, kind of 5 months into my new job. So this is where, if you don't have those processes in place, a pathway in and of itself, like the former speaker said, isn't helpful.
Yep.
So I think the pathway doesn't work without a toolkit and really, really well-structured processes, and the toolkit won't work necessarily without a pathway. So I think they go hand in hand.
Yeah, okay. So it's one of many strategies, but I'm also hearing marketing is actually important, not just marketing, but saturation, keeping up with things changing over. These are all really important concepts about sustainment when you're talking about implementation failure. So thank you for sharing. That's really helpful. Another place I've just very practically seen, because I wanted to fit this in somewhere in terms of pathways for nutrition care especially, is people look at the patient and they go, they're obese, they don't need it. Straight up. Well, it's time for them to lose weight while they're in hospital. We won't give them a high protein diet. We won't give them supplements actually, and it doesn't even matter if they can't reach their food, because let's face it, they need to lose weight anyway. Did you know that a diagnosis of overweight or obese malnutrition, or DOOM, gives an odds ratio of 12-month mortality of over 4? So basically, you're 4 times more likely to be dead at 12 months if you're overweight or obese and have protein energy malnutrition than if you're overweight and obese and don't have protein energy malnutrition. So there's a whole epidemic. It's like sarcopenic obesity, but it's just related to how much you eat. But we've got a whole epidemic of people coming through that are now overweight or obese, but are also becoming malnourished because they're finally starting to lose weight as they're getting sicker and as they're aging, and they're losing their muscle, not their fat. And so we've got to stop people from just thinking that they're using their brains when maybe they should actually follow a protocol. So that's another example of protocol failure. So develop a toolkit. Again, toolkits can fail spectacularly. They can just sit in a corner and go dusty as well. Any thoughts or comments about a toolkit? Do you want me to go back to that slide? I don't think I need to. I think we can just probably just keep going with this one.
Jack?
It does talk about interdisciplinary and multi-component nutrition care policies, pathways, processes. Can anyone just give me some examples of what you'd like to see in a toolkit? Let's just go with that. If we had an FFN toolkit that was to support nutrition care, what would go in it? Now we've got to get some interaction here, surely. We've got 2 microphones. Freda?
I got a mic now, so you can't stop me. Being a non-English speaker, as I mentioned in the beginning, am I the only one who is a bit unclear on what's the difference between a guideline and a toolkit and a process? And I was a bit late in the show, perhaps, to start.
You've got a cheer coming from behind you. Yeah, okay.
Because I've failed miserably at trying at improvement efforts, but I don't really know if it's the local guideline or the pathway or the toolkit that has failed.
Yep.
And I think one of my major reasons for I've failed less the past few years than the first years I started this, if it makes you safer. And one of my main failures have always been involvement of the local group in the planning and the education process before starting the improvement for typically hip fractures or post-fracture care, which is sort of linked to all this, of course. And then when I was sort of pleased with myself, when I told you about our nutritional work last year, it is now already clear that we have half the nursing staff at the board are new, so we have to redo and redo and redo the education. And then I think you can make the other stuff pretty simple. And I think, as we heard from Scotland, that everybody, everywhere, we want to adapt what we do to their local circumstance.
Yeah.
Anyway, so no PDFs, that's a very good rule.
Yeah, absolutely. And so what I'm hearing, and please, I want you guys to put hands up, is it's not just a toolkit of things, it's actually an implementation toolkit. And sorry, I should have made that clear. So that's not just, here's some things that you might find helpful, but here's how you actually go through that process of who needs to do what differently, what are the barriers and enablers to doing it. How do you actually map those barriers and enablers to change techniques, to behaviour change processes that can mean that that thing works? And then how do you evaluate whether or not actually that's made a difference? So it's those process things that you run through. And that's where I think if we have an implementation toolkit, rather than just a list of, here's a flow sheet and here's a, education material and here's something else. Does that sound like that would be a bit more helpful? I'm getting a nod over here from Julie, so I might, I'll get other people to put their hands up first. So I think we've got somebody over here with the mic, is that right? Yep.
Yes, I'm Teresa, occupational therapist working in Sweden on a comprehensive geriatric ward for fractures. And I was just curious, I think it was Olaf, the nutritionist who spoke earlier, talked about the kind of calculations we should consider. It was 30 calories per kilo and 1 gram of protein per kilo. I mean, these are things that are not going to happen after the person leaves the hospital. I don't think their caregivers or other people would be informed. And she said a minimum of a month. So we're going to start a treatment that no one understands how to follow up. So what's the purpose? So I think that could be something that you look at, maybe an app or something really useful that's very concrete that a person could follow up and say, oh, you need to eat half a chicken breast or whatever it is, how many grams, that type of thing. I think is very interesting, but it won't be sustainable if it's not, implemented in the chain, in the care.
Yeah, great. That's really helpful. So we're taking some notes of this as well. So, actually, it's being recorded anyway, isn't it, Freddie? So we can take some notes off it later, even better. Sorry, I might have just put you all off talking now because I've said it's being recorded, but please do keep talking. So who else we got another mic over this side? Does somebody else over this side want to talk about this? I do think this is important because it's about implementation failure is what we're talking about here. It's about the knowledge to practice gap. Any other thoughts about that? Yep, Julie? Just grab the mic, thanks.
I didn't want to say too much except that I thought that was really a good observation, so that if you have a comprehensive approach and you're able to enact that in the hospital, but your patient's only there for 5 days and there isn't an easy way to follow up or to do something like this, it's certainly not as effective. So perhaps digital would make sense.
Yeah, great. And I didn't emphasise the wording, which I should have. You'll notice it says across fragility fracture settings. So I don't mean different acute hospitals by that. I mean acute rehabilitation, secondary prevention, and also to a certain extent, I think primary prevention, although that's a little bit beyond scope of FFN as such. Great, we've got some conversation happening here. Yeah, over here.
I'm just as jet lagged as you are, I think, or perhaps worse, but I was just circling back to Freda's comment that people don't necessarily understand the difference between guidelines, pathways, toolkits. If you could define that.
Sure. Okay.
That
so,
might be helpful.
yeah. So, well, there's evidence-based guidelines that often don't even include nutrition care. So I'll give the example of Falls guidelines, for example. So I think the Falls guidelines, I'm pretty confident, don't include robust statements around nutrition. Because as I think somebody said, might have been me or somebody yesterday, you can't starve people versus feed people and then work out whether or not they're going to fall or not. Do you know what I mean? Like, it's probably not that ethical. It's not like a drug trial where you can give somebody something and somebody something else and see if it makes a difference. And so evidence-based guidelines usually require, they have recommendations that are based on level A evidence. And if you don't get level A evidence, you know, that it shows it's really good, a lot of people then go, well, we can't include that as a recommendation because it's not solid evidence. But we're never going to get that sort of solid evidence for multimorbid, frail, older people who've broken their hip, because the very people who we want to recruit into randomised controlled trials are excluded. So that's evidence-based recommendations, and I think they're probably nearly as harmful as relying on RCTs in hip fracture. I'll go so far as to say that, because I think those two things are precluding good care in a really vulnerable population, because there's something called selection bias that I won't get to today. So that's the guidelines. Then you can kind of have evidence-informed guidelines, which is around consensus statements. So that's a bit better, because then you can actually say, well, there's not enough evidence out there, but we really need to make a decision. And so as a group of people, we come up with some way of finding consensus that says, for example, all of these smart people from around the globe, from across professions, say, even though the evidence isn't there, this is probably a good idea. And so that can be quite helpful in nutrition, because if you don't have something you can take you to your executive who won't fund oral nutrition supplements because they want to save some money, or won't put in a good food service system because they want to save some money, they don't know that they're not actually following good practice. I'll come to data in a minute, because I think that's where data is actually really helpful. So that's the recommendations. Now, if you've got like what was the next one? I'm getting confused myself. I'll just go back. A pathway. So that's usually just like a flow diagram or something that says at different stages of the journey, here's some things that might happen. So it's usually a visual. It's like an infographic. So if you imagine you just have an infographic and people like that because they can follow it, it makes sense. It's not, what we don't want, and it's really clear from the conversations, is we don't want another 35-page document that nobody's going to read and it's going to gather more dust than the protocol that we heard about earlier. So maybe just a simple infographic, something like that. I'm not sure. So these are the things that we can explore. So does that kind of help so far? And then a toolkit, well, there's all different versions of toolkits, but I think this would be an implementation toolkit, which doesn't just contain resources that you can actually adapt, modify, but it also then contains opportunities to how you could implement those and carry them through. Does that make sense? So they're the difference. And again, it's probably keeping it simple is what I'm hearing from this group. So already I've lost half the group because I've used too many words about different things rather than just saying this is, probably what we need, an infographic.
With the aging population, I think we need to include the families and the environment, and especially around nutrition, because people eat in a social environment. So just be observant of which information we give to the families in hospitals, in rehabilitation, everywhere, because meals are a way you can care about people, and if you have the knowledge, a lot of the families will actually help just by being there and also providing meals. So make information materials in the way that, and include them in the meals at hospital, visiting time and so on.
Yeah, absolutely. So for example, for me, a toolkit might include a patient telling their story, just a quick patient, experience about the fact that when they were in hospital, there wasn't enough nurses around to feed them, but the family weren't allowed in at meal times, and so they starved and became malnourished while they were in hospital because they were banned from going into the hospital at meal times, and all the allied health went for lunch. Just imagine if you had that as a story, like a patient-centered story. That's going to drive some change, isn't it? So it's not just about having, a piece of paper. It can't be that dry, boring stuff that nobody goes, okay, great, another question.
Yes, my name is Vinnie Smelling. I'm from Denmark. I'm the nurse.
Hi.
And I'm thinking about we might not be alone in this problem in the world. There's a lot of other patients, older patients, chronic sick patients that have nutrition problems, and a lot of other organizations trying to solve the problem. So there might be some help to get to cooperate global.
Yeah, absolutely. So in the country I come from in Australia, in our state, we actually have something called NEMO, or Nutrition Education Materials Online, not that little orange fish that comes from Australia as well. But wherever possible, we actually point to resources that already exist rather than actually creating our new ones. And so again, a toolkit doesn't necessarily need to create new things. We can go out and find things that are already out there. So thanks, that's a really good point. I might keep going, and that way we can give ourselves an early break, because I'm checking with my...
Can I come with a comment more?
What's that? Oh yeah, keep going.
Comment more. A lot of these patients we're talking about, they are in pain. Some of you mentioned it, and they don't eat. And we don't hear a lot about pain management in this conference. That might also be a place to do something.
Absolutely, and I think again that's stories, and I've seen a number of stories around that, around difficulties with pain management and the impact not only on nutrition but also on mobilisation and other factors as well. Great, we've got a question from up the back also.
Sorry, Jack, I just wanted to clarify the FALS guidelines do have nutritional assessment.
Excellent. What does it say? This is Morag, who's from Australia.
Nutritional
and she always
assessment
sets me
including
right.
vitamin D. Assess nutritional status including vitamin D intake as part of a multifactorial fall risk assessment, followed by supplementation where appropriate.
So it says supplementation, but that's probably in relation to vitamin D, depending on how you interpret that.
But it is talking about malnutrition, so
Yeah.
it says malnutrition as well.
Great. So there's something there, which is good, but it's probably not level A evidence. So I'm glad they put it in there. We've been working. So develop a toolkit. We'll go past that one. This is something that's really interesting. So as well as having patient stories, as I said, at the other end, sometimes having hard data is useful. The difficulty is how do you actually find measures that people can collect in routine practice without making a whole lot of work for people that we can do. So this one's going to need some work to do, and so we won't take this one lightly. One that came up in one of the interviews, which was fascinating, was it was the sitting up out of bed at day 1 measure, eating their meal. And I thought that was quite fascinating, because that would actually give you some thoughts about the pain control, as you've heard, about how the operation went, another one, about the culture of the ward in terms of getting people up and out of bed. It would give so many different things. And even if you didn't really measure how much food they ate, the fact that they're sitting up and out of bed might actually mean that they're more likely to eat. So anyway, there's a few different things that are floating around, but I'm not sure how we're going to do that yet. Ideally, if we're going to follow guidelines that says everybody should get oral nutrition supplements, I think around about day 3 or so, give or take a bit, we need to be assessing whether people actually need them still, and then at that point also whether they're likely to need them for a reasonable amount of time. So I do think before people are discharged, they should both get, as has been pointed out, a thorough nutrition assessment and also an intake which includes an intake adequacy assessment as well. So has anyone got a mic at the moment, or can I go to the next one? Or does anyone want the mic? Nope. Okay, so, yep, which way? Audit, oh yes.
Sorry.
Go for it.
I think when you say data is sometimes important, data is the only thing that's going to tell you whether or not this is working. So when you're designing measures, they have to be simple. They have to be straightforward. And when you think about measurement, you keep that in your mind. We are incredibly lucky in Scotland that we have people who collect the data for us, and I know that doesn't happen probably anywhere else. But so I appreciate that things may seem a bit easier for us. But there are ways that you can do it that makes it easier. So
Anthony and I have already had some conversations moving forward, so I think we've got plenty of opportunity here. So, nutrition curriculum training and professional development opportunities for interdisciplinary players. I actually think this is one of the most important of the lot. Does anybody want to talk to me about, have we got any education people or specialists or people that are interested in this who want to tell me why this is actually something that we should focus on? Freda, education specialist.
Yeah, that was what you wanted, wasn't it?
Yep.
No, short answer. I agree with you. This is most important one of the lot.
There you go. Thank you. I appreciate it. We've got one up the back as well. Thank you. Oh, two, actually. Yeah, I'll get you to go second. I saw this one first, sorry.
So I think it is important, but I think what's really important is how you sell that this is something more worthwhile and different to the millions of other bits of mandatory training that we have to do on, recognising autism, on health and safety, on information security. So I probably have to do 24, 25 different bits of mandatory training every year. I'd do this because I wouldn't get a record if not, but unless somebody made it clear why this was important, it would be a tick box exercise, and that's the danger of putting things in curricula without really putting a lot of context to them.
Absolutely, and I am allergic to mandatory training. Working in a hospital and a university setting, I've got to do double the amount of it. And so I'm thinking this is probably more in the pre-graduate level, but it's also then for staff. And again, we've heard about turnover of staff, but we've also haven't heard about turnover of dietitians, for example, who could do that training as well. So I've got another hand over here, but we've got a mic here as well. So.
Hello, I'm Katrina Cunningham, a physiotherapy educator in Ireland. I suppose absolutely it's key to have nutrition education. My concern when we sit at a conference that's just about fragility fractures is that to design something for fragility fracture nutrition, it's setting it apart, and calling it orthogeriatric pathway is setting it apart. Are we talking about other disciplines learning good nutrition for older adults? And I have concerns about devising a lot of material specifically for fragility fractures if you've busy clinicians who don't have orthogeriatric services, and that it becomes sidelined into being part of orthogeriatric care as opposed to good nutrition for older adults when they're hospitalised or whatever the setting.
I'm just trying to remember, what was the title of our book? Did it include fragility fracture, or was it just for older people? It was part of the nursing series, wasn't it? Yeah, so the answer to that is one of those books that we showed up before. We actually made that as an active decision. So thank you to both Karen and Julie for hedging us that way to say. So one of the books we've written is actually interdisciplinary care for older people in general. So, and that's focused on nurses as champions of interdisciplinary nutrition care processes. So, but it's focused on the whole team. And so we introduced the first chapter of that, talks about siloed professions. It's a good read if you want to check that out. That's a great question. Now the mic went this way.
Yeah,
Julie?
me, sorry.
Can you put the mic just near your mouth?
Apologies. Katriona, funnily enough, and I were talking about this earlier in the education workshop. And my concern about this is that there's 101 different ways of doing this education thing. And unless you do it in education embedded inside the team, it doesn't have an impact on that team's practice. You can educate everybody separately and they know stuff, but if you want them to do stuff, then you have to do it inside teams with cake.
Yes, so that was the last presentation. As a dietitian, I'm a firm believer in cake. If you've got an interdisciplinary team together, and if somebody's got a mouthful of cake, they're actually going to tell you what they think, even if it's a bit harsh. And that's important for good team care, because they say it with a smile as they're eating cake, and who can get upset when you're eating cake? And so, or, some other culturally and socially relevant food, of course. But it's a good point you make. But on the other side of it, when you've got high turnover in teams, if you work in a, say, rural or remote area where staff turnover really often, you're better off actually probably putting systems in place. So again, these things need to be tailorable. So where you can't keep the education up, you've got to put blockers in place. You've got to put things that people stumble over. You need prompting things in electronic medical records. It's a totally different approach. And this is where a toolkit approach needs to not just be focused on, for example, a high-income quaternary hospital that's got all of these resources and care-driven in silos. Research, you can come and talk to me about this later, but it would be fair to say that there's not a great deal of research out there, but I think there's probably enough for us to actually just do good nutrition care. And I think I'll leave that at that. Like, I am a principal research fellow. I get paid to do research, but sometimes we actually just need to actually focus on implementation. And then if we do the implementation right, we'll actually see our numbers get better. And that to me is publishable. If I won't ask people to talk to this because I need to talk to the FFN exec team about this first, but if we look like we're going to go with something like this at some stage, we might put out an expression of interest. So in the meantime, if you're sitting here, it means you're at least vaguely interested and probably quite interested. So I'm jack.bell. Actually, just come and find me and I'll give you my details. So that's my first screen. If you actually come and find me, it means you're really interested, and then I can give you my card, which I don't have, and then you'll have to contact me again so that I remember to send you an email. So that's my screening process. So I won't talk about that one. And did anyone have any additional things that they thought they were priorities in the last couple of minutes that they'd like to share? Okay, so we've got a hand over here. And did you put it in the survey?
Yeah, I put it
great.
in the survey as well. So my name's Ole. I'm a geriatrician from Norway, and my hip fracture patients that I really struggle with are my dysphagia patients. And so I need help handling those.
Sure. So I'm going to be really controversial here. Do you think you see more people that are having issues with malnutrition and sarcopenia than you are seeing who are probably having issues with aspiration pneumonia related complications?
I agree that dysphagia is a problem for a minority of patients. And that's one of the problems when we're such a large and diverse group here from a diverse range of backgrounds and resource settings. A lot of nutrition works is getting the basics right, and then sometimes you need more than the basics.
Absolutely.
And me personally, and my ward, we struggle with dysphagia patients. They have delirium, they take out their tubes. It's a struggle trying to get them enough energy. It's a struggle, and having a set of pathways or guidelines or something like that would enable us to go to our hospital administrators and ask for more speech therapists, being able to have that patient who for a few days longer in hospital to delay that transfer to the secondary care facility, things like that.
Great. So I work quite closely with a few speechies, one of who wrote the chapter in the book about dysphagia in that nutrition management for older people. So if you start looking in that chapter, and if you want the contact details for any of those people, let me know. But I've got plenty of other contacts as well, so happy to put you in touch with people. It's a really hard one. I've seen people die basically because they had nasogastric tubes put in and then they half pulled them out overnight, and so you'll see there's recommendations now to say probably don't feed people overnight with nasogastric tubes who've had a hip fracture. I've also seen plenty of people who've aspirate because they didn't get screened adequately for dysphagia, and so they also died. And then I've seen plenty of people who've had really, really poor quality of life and bad outcomes because they were starved for too long. And for those who weren't at the lunchtime session, it doesn't take very long for your quads to get chewed up as food. And most of our older people in hospital, especially with hip fracture, need just about all of their quads to get out of bed. So once they've lost 1.5 kilos of them, then they're gone. They're to a residential aged care home. And that's the end of the story. And that's the end of the story because I think we're out of time. I think I'm right. So yes, so that is time. Is this about time? I think it is. So if you haven't completed the global oral nutrition supplement study yet, it's right there. It takes under 6 minutes to fill out, so you can feel free to do that and then add some more data into that thing. If you don't have to, that's fine. It's totally up to you. Thanks so much for coming. And